Hi, this is Dr. Kelly Williams, and I am from the Medical University of South Carolina. I'm our CIS ECI moderator for the evening. We have a great case for you guys, and it will be presented by Dr. John McDonnell. He is an allergy immunology fellow at Cleveland Clinic, and his internal mentor, Dr. Lesmana, who is hemonc and genetics trained. And then we have our senior and expert mentor, Dr. Neil Romberg from CHOP. John, you can take us away. Oh, wait, two other things I just want to say before. Sorry about that. One, we're not going to have a webinar next month because of the annual meeting. So instead, please register for the annual meeting, and there's lots of good learning there. But no ECI webinar next month. So please make a note of that.
Thanks for the introduction, Dr. Williams, and thank you all for letting Dr. Lesmana and I participate tonight with hopefully an interesting case. This is the case of fever and severe diarrhea in a neonate. So this is a patient that presented to us as a 2-month-old male. He was originally at one of our hospitals in our overall system, admitted at that hospital for dehydration and possible shock with ongoing GI losses. And so what had happened is he was born at 36 and 3 via C-section. Prenatal course was complicated by maternal type 1 diabetes. But after he had his delivery, his perinatal course was pretty uncomplicated. However, around 6 weeks of age, he developed severe diaper rash and kind of was associated with this really bad diarrheal illness, like having stools all the time. So he actually presented to one of our partner hospitals with yellow emesis. That was a one-time thing, fever, blood and stool, and copious diarrhea. So after a few days in the partner hospital, he was getting more and more sick, looking like he was developing hypovolemic shock, diarrhea, vomiting, becoming somnolent, cool extremities, and actually had some hyperkalemia. So he was pretty quickly transferred to our main hospital, where he was cared for in the peds intensive care unit. I'll tell you a little bit about his course there, but it was complicated by continued diarrhea throughout his hospitalization, DVTs affecting his right upper and right lower extremity, anemia that required transfusions, and of course, the diarrhea just kept going and going and going. So, a number of specialists were involved in his care, not only the allergy immunology team, of which I'm a representative, but obviously our GI team was involved, monitoring his hit to his liver that he undertook, transaminitis, INR, which was high initially but resolved with vitamin K administration. Hematology was on board, monitoring his clots and his subsequent heparin dosing. Infectious disease obviously played a critical role because we were like, what's going on with this kid? Why is he having endless diarrhea and having fevers and such? And then the neurology team was on board as well because he had at least one episode of just total unresponsiveness for about 10 minutes. And at that time, EEG leads were put on him, and he didn't have any seizures, although the report did mention kind of a generalized slowing during that episode that resolved. So allergy was consulted to kind of weigh in a little bit. We obviously had the other specialists on board. At that time, I came to saw him with my attending in the peds allergy department. He had started to develop a red, itchy appearing rash that was on his face, starting on his face, and then kind of settled in his extensor surfaces. And mom just kind of mentioned it like, oh, yeah, he's had this rash. No big deal. I've been just putting some Aquaphor on it that I have in my purse. And then when we talked to the family, they said, yeah, he's still having a lot of stool, although that's actually better now. He's only having 10 a day, or a little bit more than 10 a day. And that's actually better since we started him on TPN. So I got more of the history. So again, primary case is this child with initial vomiting, that part resolved, but then continued diarrhea and these other kind of somewhat different symptoms affecting him, including the clots and the neurologic slowing, et cetera. So I asked about the family history. Mom had, the history of type 1 diabetes that was diagnosed in childhood. She also had a history of autoimmune thyroiditis. Her uncle and grandfather had HLA-B27 mutations, but I didn't she didn't really know much about that other than they had these mutations and had some seasonal allergies. His father had seasonal allergies, and one of Dad's relatives had ulcerative colitis. But the family history was otherwise negative. From a review of systems standpoint, just kind of focusing on what's important for us, the vomiting, as I mentioned, that had resolved after transfer. The yellowish vomiting that he had was just a kind of a one-time thing. But the diarrhea was still ongoing, again, around 10 plus diarrheal stools a day, even on TPN when he was not on any formulas anymore. Occasional staring spells with not associated with any EEG changes other than slowing, and then now this itchy rash. I just wanted to ask if there's any questions so far about the presentation before I give you, other things, labs and such.
Okay, we got nothing in our chat.
All right. Well, then I'll
Anybody
keep
have any
going.
questions so far that they want to put in that I can I bring up? Or if not, we can continue with the case and continue with our discussion. Okay.
I'll just think that I have you guys in rapt attention. So carrying on with the case. So his exam was a pretty good size for a child of 6 weeks. Thyroid function, I saw that pop up. I will give you that.
What
And I'll
about
come back to the DVT. So the DVT was, from my understanding, ultimately ascribed to the fact that he had had such severe dehydration. So he was proven by ultrasound and monitored, but it didn't become a recurring problem. And my understanding of that was, again, he was just so profoundly dehydrated. The thyroid function. I'm sorry, I'm gonna keep reading, and then maybe Kelly can tell me when something to respond to. So the weight was 5.3 kilograms. The patient was non-dysmorphic. And then he had this rash, but it was pretty nondescript, maybe looking a little bit eczematous to me as the allergy fellow. I reviewed all of his procedures and stuff that had been done in the hospital. He'd had a very abnormal EGD and colonoscopy. The upper part of his GI tract, including the duodenum, had villus blunting, intraepithelial lymphocytosis, and some areas of neutrophilic injury. And then he had some gastritis in his stomach proper. Then going down to the lower GI tract, his terminal ileus was had partially denoted mucosa, ileum, excuse me. And he had villus blunting and focal neutrophilic injury, and then a lot of active colitis, deep crypt dropout. And so, very abnormal colonoscopy. So the labs, thank you, Dr. Lesmana. The thyroid function was normal, and a number of the labs that we all probably have on our minds. Hopefully, I've got most of them here. So this was, I believe, pre-transfusion, anemic. ANC and ALC were normal. His total protein was predictably low. His albumin was low. His immune cell flow cytometry, looking at populations of T cells, B cells, and K cells, was normal.
Okay, I think we lost John. Maybe Dr. Lesmana, Lesmana, can you continue on with a little bit?
Yeah, absolutely. So,
sorry about that.
No problem. So we did collect some labs on these patients. Again, this is just a summary of pertinent labs that we collected on him. So the patient was anemic at the time with hemoglobin of 6.9. The white cell count was normal at 8, and platelet count was normal at 168. We think that the anemia was probably related to the frequent blood draw because the patient had multiple diagnostic labs collected during that time, and this is only a few pounds baby. So we thought it was all related to the frequent blood draw. We did see some aberration in metabolic functions. The total protein was low at 3.1. Albumin was also low at 1.5. So we did perform lymphocyte subset on these patients, and it was all normal in these patients, both for T cells, B cells, and the NK cells, both absolute numbers and also the percentage of each subsets. The immunoglobulin levels, again, we didn't collect IgG because it's just a few months old, but it seems to be normal for IgM for his baby, and IgE was very mildly elevated. I'm not sure if I can advance this. Okay, so obviously as part of Workup for these patients, because he had a quite remarkable diarrhea, and the first thing we'd like to exclude is all the infectious etiology causing gastroenteritis, and it was all negative. We also swabbed him for COVID-19 and multiple other respiratory viruses that can also present with causing diarrhea. And so all the extensive workup for infectious disease was negative. The ferritin levels was elevated in this patient up to 841, but the CRP was normal, and there was one mildly elevated CRP at the beginning of the presentation when he had fever, but it was all normalized subsequently, and the ammonia level was normal as well. So because of concern of an underlying autoimmune enteropathy, I think that the concern was brought up after the GI result, the GI biopsy showing some finding that might be consistent with autoimmune enteropathy versus early onset, very early onset inflammatory bowel disease, and the fact that there's a strong family history of autoimmune disorders, especially in the maternal side. There is concern for possible an underlying immunodeficiency or immune dysregulation. So genetic was consulted, and one of the decision was to send a more broader genetic panel. The GI team decided to start him on systemic steroid, and with much improvement on the diarrhea. The patient was initially TPN dependent, but was able to be weaned off the TPN and transition to fully hydrolyzed formula that is easily digestible. And the patient was transferred to a regular floor and final discharge home. Next. All right, so I will.
Sorry, I'm going to take a pause right here. I think John's back, but also,
Okay.
I want people to stop and maybe think about if there are additional questions or also things they want to start throwing out there for a differential. Kate Sullivan's asking about a slightly elevated IgE and whether that could be suggestive of a certain process.
Yeah, so I'm sorry that I dropped off there. But yes, that the elevated IgE was definitely something that was concerning to us as the allergy team, immunology team as well, and all the subspecialists. And that was one of the top items in our differential was going to be an IPEX or IPEX-like syndrome.
Yep, that's what everybody's in the attendee chat is also suggesting. And they're asking if you got any FOXP3 staining in the colonoscopy, the gut biopsies.
No, that's an outstanding idea, but we did not do that.
And was a DHR performed?
No, that's another good idea. We actually, because we had a program, I don't know if Dr. Lesmana had talked about this yet. We had a partnership with the McDonnell Foundation where they give a certain number of genetic tests. We decided that maybe the better part of valor was setting off a genetics panel for immunodeficiencies. So we were kind of holding off on other testing and trying to get the sample sent to the lab to have genetic testing performed. So we had thought about getting other tests performed, like through other institutions, but we were kind of putting our hopes into that genetic panel because we were all thinking it would be a mutation that would be on that list of 404 genes.
Okay. Someone also is asking about the size of the platelets and thinking about possible Wiskott, whether you had big platelets in the smear.
The platelets were of normal size. It's a good question.
Any other abnormalities on a smear or no that you recall?
The smear was completely normal. Yeah. And then actually hematology was also consulted because of that downtrending platelet counts. Actually, throughout the admission, we didn't show the trend of the labs, but there is some evidence of evolving cytopenia. First, it was anemia, but we thought it was related to frequent blood draw, but the platelet count started to drop as well. So there are some concern for some evolving process like HLH in this patient, but it was not severe enough that we ended up doing additional testing because once the patient was started on steroid, the clinical status is improving.
Okay, great. I think we could continue. Oh, someone also suggesting Omen syndrome, possibly. If you want to continue on.
Okay, so the testing, the genetic testing finally did come back, and looking at that, where our eyes were drawn was where the red box is. So this substitution of aspartic acid going to glycine that was found in the NLRC4 gene, the 99th codon. That was where we were looking because it seemed like, at least kind of based on the overall phenotypic features of this inflammasome problem, our patient seemed to have some of those potential symptoms. But of course, it was a variant of unknown significance, so we were kind of scratching our heads wondering what to do. And so Dr. Lesmana has a great literature review come in here about NLRC4 related autoinflammatory disease.
Thanks, Jack. So just to review the genetic testing results. So we did see 3 VUSs on that PID panel that we sent to Invitae Genetics. The one that we are most concerned about because it's clinically might fit with our presentation, our patient presentation, is the variant in NLRC4. So this variant in NLRC4 has not been reported in the past to be associated with NLRC4 related autoinflammatory disease. And when we look at the location of that particular mutation, it's located in a domain where other mutations has been reported to cause NLRC4 disorders, but this particular position has not been reported to cause that disease specifically. And then we are aware that this is a rare disorder, so there might be some novel mutations that has not been identified or further explored. And when we look at the population database, the mutation itself is quite rare. It was only seen one time in Genomed, and it affects a highly conserved domain of the protein, of the NLRC protein. It seems like it's in, I'm not pretty sure where is it really located. Maybe Dr. Romberg or Dr. Khanna might be able to comment about the actual location, because it seems like in between the CART domain, and also the NBD, which is the nucleotide binding domain, which I'm going to explain further on. So NLRC for autoinflammatory disorders, related autoimmune disorders, is a part of a systemic autoinflammatory disease. So we know that this is a condition where there's an abnormal activation of the immune system, causing all of these inflammatory symptoms in the absence of triggers like infection or autoimmunity. And there are monogenic forms of these conditions, such as many periodic fever syndromes like familial Mediterranean fever. There are also conditions, autoinflammatory disorders that can be called as polygenic conditions, like adult onset still disease. When you look at, this is from the review paper from clinical rheumatology, that there are probably about 7 different mechanism why a person can develop autoinflammatory disease. And obviously the most common one is that has been well described and well studied is this group of condition called inflammosomopathy, which is conditions where there is mutation in the molecules subunits of the inflammasomes or the other interacting proteins. And that will include many of the periodic fever syndromes. Many of the NLR mutations are lumped in this condition of inflammosomopathy. There are also other conditions, including those that is caused by mutation in the TNF receptor called TRAPS that causing some sort of reticulum endoplasmic stress, because there is some issues with misfolding of the protein as a result of that mutations. There are also conditions that are caused by mutations that affects the regulation of the NF-kappa beta pathways, either because of the gain of functions or loss of function of mutation of those that kind of regulate the activation of NF-kappa beta pathways. Another conditions that can also cause autoinflammatory disorders, including ADA2 deficiency. It just seems to be in a certain box of autoinflammatory disease, and then obviously the other two that are recently described as well is the group called interferonopathies and actinopathies. But for this webinar, we're just going to focus on the inflammosomopathy. Next. So this is a group of disorders because of excessive or inappropriate activation of the inflammasomes. And there are many mutations that has been reported. And this is in the order of frequency. It seems like the mutation in pyrin is the most common one. Then well-studied inflammosomopathy that causing periodic fever syndromes. There are a group of disorders because of mutation in the NLRP3 causing NLRP3 autoinflammatory disorders that was previously called as CAPS or cryopyrinopathy-associated periodic fever syndromes. The one that we are going to discuss today is the NLRP4-related autoinflammatory disorders. There's also NLRP12, PSTP1-related autoinflammatory disorders, and mevalonate kinase deficiency, what we call as probably known as hyper-IgD syndromes. And all of this inflammosomopathy is characterized by very unique signatures where there's an activation as the end pathways, the activation and the excessive production of interleukin-1 cytokine family that will include interleukin-1 beta and interleukin-18. As you can see here from this, can you go back real quick? Yeah. That there are 3 main components of inflammasomes: the adapter called ASC, the whatever NLR mutation, NLR protein in this figure, it's NLRP3, and the caspase, which include one that will oligomerize together in the setting of appropriate danger signals that comes into the cells, and then will create this complex of inflammasomes that will result in the activation of pro-caspase-1 into an active caspase-1, with the end result of cleaving, which has the proteolytic activities to cleave this pro-interleukin 1 beta and pro-interleukin 18 to an active form, and then subsequently led to the apoptosis of these inflammatory cells. Next. So specifically about the NLRC4, this was first described in 2014, and we are glad that both of them are here in this webinar. So one from the NIH group, from Dr. Scott Canna group at NIH, and the other one from Dr. Romberg group at Yale and University at that time. And concurrently describing two families that presented with very unique presentation characterized by enterocolitis and some evidence of macrophage activation syndromes. And both group identified this gain of function in NLRC4 gene that has a unique presentation causing autoinflammation and infantile enterocolitis, although it kind of mimicking what NLRP4 related disorders, but it does have some unique presentation because GI manifestation is not typically seen in NLRP3 related autoinflammatory disorders. So it has been listed in OMIM as AIFEC, what we call as autoinflammation and infantile enterocolitis, and the unique part about this autoinflammatory disorders because it specifically can trigger this macrophage activation syndrome or HLH-like presentation, where a few cases that has been reported had been fatal in the past. And then shortly after that two reports, there's subsequently a Japanese group that reported another pedigree with some neonatal onset, but much milder presentation and more similar to what we see in NLRP3-related disorders causing familial cold-induced urticaria. So they presented similarly in that conditions, not as severe as the younger patients. And this also was listed in OMIM as familial cold-induced urticarial rash syndromes. Next. So today, to my knowledge, based on my literature review, there has been over 30 cases reported, and despite being a rare disorders, it seems like we could see some clear. I don't know if it's a good way to say it, if it's really clear genotype-phenotype correlation, but it seems like there are two observed phenotypes. The type 1 is the one that presented early on, like the two cases that reported by Dr. Canna and Dr. Romberg, that has a very early onset with high mortality rate, and most of those patients develop high fevers and has HLH-like or macrophage activation syndromes during their initial presentation, and has this very unique GI presentation that kind of mimicking severe early onset inflammatory bowel disease, and some of them also have this non-specific skin eruption. The second phenotype is the one that reported by the Japanese group with more milder, older onset presentation, with more urticaria and skin symptoms other than the GI symptoms. And to date, there has not been any, for the second phenotype, with any kind of organ involvement, growth retardation, or mortality. So I put a snippet of the figure from the Romberg review paper on NLRC-related autoinflammatory disorders, that those mutation affecting the WHD domain seems to be associated with the milder phenotypes or phenotype 2, while those that affecting the HD1 domain or the NBD or the nucleotide binding domain are associated with more early onset and more severe phenotypes, as we see in type 1 of this condition. And as you can see, based on, if you remember, our patient's mutation, it was located at 150 amino acids. So it's a little bit closer to the, I think still at NBD, and I'm happy to ask, sorry, it's in amino acid 99, which is, it's unclear whether it's at CART domain or at nucleotide binding domain. Next.
If you want, we can pause and we can actually, do you want Neil to comment on different areas there? Oh, Scott also, so Dr. Romberg, if you'd like to comment, and then I can read what Scott Kenna just put in the chat as well.
Hello, thank you. I think that the position, the MBD starts at codon 95. So this would put it in the NBD domain, but at a very different position than the other mutations that were previously identified. And I did have a chance to look at this, the conservation of NLRC4 around that region. I would say I would not describe it as highly conserved. I would say perhaps moderately conserved is probably an accurate description. There are quite a few single amino acid substitutions actually at the 99th amino acid codon described in Nomad, including the one that is described that you describe in your patient. Now, some patients in Nomad actually have diseases. We don't actually know the phenotypic information on those on everybody in Nomad, but it does give me pause about if this actually is your patient's molecular diagnosis.
Okay, that's a good pause. We're going to come back and talk to you and get your input in just a bit. I'm just going to read two things from the attendee chat too. And Dr. Scott Canna said, for what it's worth, position 99 in the mouse, which is what the crystal is based on. Nevertheless, ASN 99 is not particularly near the ADP binding site by the 3D structure. And then you just alluded to some of the prediction stuff, but Ivana, I cannot pronounce that name, Askievich, is asking about in silico predictions for this variant. Do you know that, Dr. Lesmana?
Yeah, those are mostly conflicting. So that's part of the challenges as well in interpreting these variants. I think another thing that we are thinking about I didn't actually look at the CAT score on this patient, which I could probably have done, but I apologize, I didn't have the CAT score on these patients. But we did ask for parental testing, which we can update later on subsequent slides.
Great. We'll move on. Sorry about that. Let's continue to discuss about this possibility of suspected inflammasomnopathy.
Yeah, so this is the what I could gather from several literature that when we suspect inflammasomnopathy or interleukin-1 mediated autoinflammatory disorders, you would like to see this interleukin-1 signatures such as fever and tachycardia, and some elevated inflammatory markers including ESR, CRP, ferritin, and fibrinogen. And specifically, you will see an elevated serum interleukin-18 levels, and it seems like we can see on our patients as well that interleukin-1 beta is generally a little bit quite difficult to be detected in this type of conditions. Since this is a condition that majority of the time only affect the innate immune system, that most autoimmune markers are typically negative in these conditions. There are some very rare, not rare, I guess, there are some other flavors of inflammasomopathy where there are some autoimmunity involved, but the majority of the time, those conditions do not have autoimmunity involved, or not the predominant phenotypes in inflammasomopathy. And there are some specific pathology that can be done. You can get some idea based on what type of infiltrates that infiltrating the affected organs, either in the guts or whatever the skin biopsy that was performed, and specifically can do immunohistochemical staining on CD133 to look for lymphohistiocytic infiltrates. And another study that can be done is also looking at the inflammasome activation on CD14 positive monocytes that after activation, after induction with LPS or lipopolysaccharide, can be done on research or clinical testing. And finally, because there are such a genetic heterogeneity of this condition, we still recommend getting a genetic testing using next generation sequencing that will have a pretty good coverage, because there are some of this condition that postulated to be due to more mosaic condition, and that has been hypothesized to be the reason why some of this condition present a little bit later onset or milder presentation because of the mosaicism of the mutations. Next. So there are several treatment options that has been proposed. Again, this is a rare disorder, so we don't have randomized controlled trials, but obviously there are a lot of case report or case series reporting the use of multiple biological agents. The most common one that has been used is interleukin-1 and inhibitors, and literally that response to interleukin-1 inhibitors is probably a defining features of most inflammosomopathies, and there are many different agents or types that you can use depending on how it works. There are anakinra, canakinumab, and rinosertib. The newer one that is more targeted towards the driving cytokine, which is interleukin-18, especially in NLRC4 related condition. There are a binding protein for interleukin-18 that has been used, and there's also a clinical trial using tadekinic that's specifically targeted for NLRC4 related macrophage activation syndromes or any other autoinflammatory disorders that can cause macrophage activation syndromes. There has been some report using rapamycin for macrophage activation syndromes. And there are some data, or maybe anecdotal data, of using low-dose steroid and colchicine as prophylaxis, and some other also recommend using anakinra as prophylaxis when the patient in between flares up. Next. So, John, do you want to continue on this part?
Yeah, sorry about that. I actually had trouble finding my name on the list, which is a bizarre problem. So yes, thank you. So patient as an outpatient has continued to do well. He is on a very slow steroid taper, following with primarily our GI service as well as Dr. Lesmana. We have we're going to get there. We're going to get there to the IL-18. We have to make you work for it a little bit. So we are very interested in whether, what this all means. So we got some targeted VOS testing for the parents. But I'll go to what you want first, which is the follow-up labs. So you can see the number of immune interleukin labs that we have here. IL-10 was elevated. CD25 was elevated. The IL-18 was elevated. The patient was on steroids. The normal range, 89 to 540, and it was elevated to 1101. So elevated, but perhaps maybe not as elevated as one might think for a slam dunk diagnosis in this case. So we are really kind of bringing this up to the group because we're hoping to benefit from your expertise and experience. So as far as any suggestions for further workup. So at this point, we are, the cytopenias have resolved. Thank you for asking. At this point, we are coordinating. We've talked to several of the doctors at CHOP. And the patient is going to be seen in their immunodysregulation clinic. We are also working on getting the CD14 LPS-induced CD14 monocytes. But really what we're wondering is kind of based on the level of the IL-18 with the patient on steroids, it's elevated, but perhaps not as elevated as one would traditionally expect with this disease. Would there be a utility for using an IL-18 binding protein? Maybe asking the group the benefit of another kind of prophylactic strategy. So this is where Dr. Lesmana and I are hoping to also benefit from your experience with this patient, because we're at a point where we're trying to figure out what to make of this.
I think Dr. Romberg kind of already alluded to some of his or thoughts earlier, so maybe you can chime in here on the pathogenicity concept of the variant.
Thanks, Kelly. I do think that the clinical phenotype is consistent with AFEC, which is also known as NLRC4 MAS. But I would say that some of the laboratory values make me question that NLRC4 mutations are the thing that are driving the patient's disease. The patient's IL-18 was like 1,000. Is that correct?
Yeah, it was like 1,100, I think.
1,100.
Yeah, I think there are parentheses next to that saying that it was the patient was on steroids.
Yes,
Yeah.
it was on steroid. That's the reason why we are also asking guidance if steroid typically affect the levels of interleukin 18 in this type of condition.
Thanks, Harry. The interesting thing about AFEC patients is that when they're really ill in an acute episode, all of their acute phase reactants go sky high, and their IL-18 is also sky high. But between episodes, when they're totally well, their IL-18 remains sky high, and by sky I mean like probably 10,000 to 100,000. So a couple powers of magnitude higher than what you're describing, and really it's not influenced by the addition of immune suppressive medications. So I don't think that really the steroids can explain why the IL-18 is not consistent with other patients who've had AFEC, and given there are not that many AFEC patients out there. One of the cool things that Scott Canna, who's on this webinar, had shown was that it's not just the total IL-18 that matters, but the free IL-18, the IL-18 that's actually active and not bound up by IL-18 BP is probably the thing that may matter in this disease, and I wonder if getting that would be helpful. And then I think absolutely the ability for Roshni to take your monocytes from your patients and incubate them in LPS overnight and look if they are constitutively activated, making inflammasomes that are turning pro-IL-1 cytokines into active IL-1 cytokines. It's a great idea. It's a really useful and sort of DIY functional assay. I didn't know she was doing that. She looks like she's doing it now on research purposes. But it'd be great if she put that online for a clinically affordable test.
And I think the other thing, I think for some reason the slide was not there, that we did collect parental testing. So, and we know that the mother was not the carrier for these variants. And I just got a phone call earlier today that the father is preliminary negative as well. So it looks like it's going to be a de novo mutation, although it's not confirmed, final release. So that's kind of raising a little bit of the pathogenicity of because there are 3 VUSs there, and the other 2 are inherited each from one mom and dad. But the NLRC4 seems to be a de novo mutation as well. And if you look at the interleukin 18 levels here, it seems like it fits with the Neonate spectrum, the one that has been reported in NLRP3. So I was wondering if this is more like not really like we call it hypomorphic, I guess less gain of function than the typical that has been reported. What's your thoughts about that?
So you're absolutely right that we should always, as immunogeneticists, prioritize de novo mutations, because there are only about 1 de novo mutation per chromosome per generation, and most of those de novo mutations are non-coding DNA. So the chance that a person with a rare disease has a mutation in a gene that is de novo that could potentially explain it is a lightning strike, right? So this is a possible that it's a chance occurrence, but it would be a really incredible coincidence. So I think it's smart to prioritize that, and it sounds like it may or may not be a de novo. You're not sure, but it seems it's trending that way. I think at some point somebody had mentioned that it may be worthwhile to think about chimerism in this patient. It may be you're looking at the DNA in the blood or in the
we are testing the blood at this point, but it seems like they are reporting it at 50%, close to 50% variant allele fraction, because it was reported in the germline testing. It was not. Most of genetic testing report will report if this is mosaic, if it's less than the typical variant allele fraction that you would expect. But it seems to be heterozygous in the blood.
One of the really cool things that's Scott Canna, who's on this webinar, had pushed forward is the idea that that IL-18 can also be created within the gut, and he had some really elegant mouse experiments showing that you could transfer elevated IL-18 levels in mice by doing you could not transfer it by an adoptive transfer of hematopoietic cells, but you could isolate the IL-18 production from the gut of mice. So, I mean, you're looking at chimerism in blood cells, but perhaps the answer may be actually in enterocytes or other cells in the gut that are making inflammasomes. Regardless, you know that in the blood of the patient, it's 50-50, so that monocyte study that Roshni is going to do, I think it's really going to be helpful. One thing that I would think about additionally is that the genetic testing you've done to this point, I think, has been pretty general but targeted, and it may be also useful at this point to think about doing a whole exome or whole genome on the trio to really sort of scour all of the potential possibilities of genes that are both known to cause disease or genes that encode parts of inflammasome machinery, because it may be that this is a bigenic case where there's a mutation in LRC4 which is not sufficient to cause disease, and then there's a second mutation in another gene which actually may be the thing that's bringing this to the surface. I think that's a compelling idea, and I think it's easily testable through clinically available whole exome or whole genome sequencing.
Yeah, I think that's a great idea to make sure that you're not missing on any other mutation that potentially can be a modifier. Like some patient with CTLA4 reportedly has some other modifying genes reported in some of the case report out there that modify the expression of the disease. So I think that might be worth to be done on a research basis.
I'm just going to read two things from the chat, which I think are relevant. One was the CAD score of 21. And then Scott Canna said, worth noting that intestinal symptoms in other AFEC patients largely resolve outside of infancy, whereas IL-18 and autoinflammation and MAS susceptibility persist.
Yeah, that's the thing that we are worried about these patients, because, since, if we really think that this is an LRC4 related autoinflammatory disorders, the GI symptoms might resolve as the gut flora is changing and stuff like that. But what is the likelihood of this family or this child in the future will get into this flare of hyperinflammatory reaction causing MAS or HLH-like presentation? And is there anything that we could do to prevent that from happening? Again, the child is only 4 months old at this point, and so it's kind of wait and see. But I think the family would like to know if there's any prophylaxis that you would recommend on this type of situation.
Yeah, the other thing that I would think about, Harry and John, is CGD is a very among the PIDs, it's a more common diagnosis for sure than AFEC. and it also causes early onset IBD. It can cause acute inflammatory markers to rise, and there's certainly there's a great functional test for it. And just because I think your targeted genetic panel is negative for CGD genes doesn't mean there couldn't potentially be a intronic or splice site mutation for a CGD, and I would totally recommend a DHR on this patient. It would totally change the way that you think about this patient, treating this patient, and both in the short term in terms of prophylaxis and in terms of transplant. CGD is a transplantable disease. AFEC is certainly not, in my opinion. So I would recommend you do that. It's a cheap and doable thing for you to try.
And as Amit actually just posted too, NCF1 is a pseudogene, so it's missed on NGS or any of the gene chip sequencing. So a DHR would be a nice functional way to evaluate that.
Definitely.
Anna also mentioned, or suggested making a mutant construct and checking IL-1 and IL-18 production. And Scott Canna just posted, if it's truly de novo, we can plug it into an assay we have here in THP1, and that amount of IL-18 will not be associated with detectable free IL-18. I think probably you guys could start an email, and Dr. Canna and maybe Ivana and Dr. Romberg will probably can make other suggestions afterward as well, offline. This is a great case, very challenging, and from a treatment standpoint, it sounds like even more challenging from trying to find a steroid-sparing agent for your child with an unclear diagnosis. But thank you so much for presenting a great case. Just a reminder for everybody else, if you guys have great cases, always email us at CIS. We're happy to review and try and get you guys on the docket. Okay, I'm not, sorry. Always looking for new cases, so if you have one, just email us and we will, as ECI, evaluate and try and add you to our monthly webinars. Again, a reminder that we do not have a webinar next month. We have the annual meeting, so look forward to that. And I think Morgan, I know we're almost toward the end of our time. Morgan is going to upload my quick slides. We always spend the last 5 to 7 minutes of our webinars with just a hot journal article review, something that came out in the last 4 to 6 weeks, and that we think is clinically relevant to everybody. And while this was just a letter to the editor, I thought it was it hit an area that's a little bit challenging to treat. So this is it was in the Journal of Clinical Immunology recently, and it was looking at the use of soluble IL-2 receptor as a biomarker for granulomatous disease and CVID. So just a few quick slides. The objectives were originally they just wanted to identify and look at the clinical and immunological features that may be predictive of GLILD and CVID patients. And specifically, they were looking for a biomarker and the role of soluble IL-2 receptor as a biomarker to diagnose and monitor for progression of granulomatous disease and CVID. So it was a retrospective chart review of clinical laboratory immunologic features of 48 CVID patients. They also compared and looked at compared them to a cohort of sarcoidosis patients as well as healthy controls, and looked at the soluble IL-2 levels in all of those. So, and this is just a quick figure looking at CVID IO is with infections only, and looking at those and comparing to CVID patients with granulomas, and then comparing them to sarcoidosis patients. And so there's statistically significant difference, and CVID patients with a granuloma group had significantly higher soluble IL-2 level than those with just infection only. And then soluble IL-2 levels increased with progression of granulomatous disease. And so there's another figure that I'll show you in a few other patients as well. And then this figure is looking at the high IL-2, soluble IL-2 levels, and looking at the sensitivity of the test. And so they actually found a cutoff, and I'll show you this in a table as well, but they of a level greater than 6,376 is clinically valuable for distinguishing CVID patients with granulomatous disease and those with non-granulomatous disease, so just infection only or other CVID patients. So I found that to be interesting and hopefully maybe useful in the clinic, because I think a lot, patients with CVID and granulomatous disease are very challenging. And if we could know about their trend toward that direction sooner, that would be wonderful. So these are 6 different patients with CVID, and following their soluble IL-2 receptor levels, and then showing that even when they treated them for GLILs, so they presented and their levels went up and they developed granulomatous disease, they got treated for their granulomatous disease and started to have good response. So started having good response, and you see these levels decreasing. And so this is a different patient who got treated multiple times in different ways for the granulomatous disease. And again, when they had a relapse, the numbers went up, then they went down. And so I thought this was really interesting. Looking at it from a table, from the clinical and immunologic features, they looked at a variety of different things, including splenomegaly, autoimmune cytopenias, IgA levels, and splenomegaly was found to correlate with granulomatous disease. So both splenomegaly and then the soluble IL-2 receptor levels were statistically significant as a clear indicator of granulomatous disease, and the likelihood ratios were important too. So I thought that was also, and so notably, for instance, cytopenias were not suggestive, and the IgA was not suggestive. So then this table is looking at the comparison between different groups, the healthy controls, those CVIDs with just infections, those with just autoimmune disease, those with granulomas, those develop malignancy, and then sarcoid patients. And of them, it was very clear that the patients with granulomatous disease have higher soluble IL-2 receptor levels. And so right here we have good specificity of that. And 100% of the patients had a level that was greater than 2,500. And when you compare it to other things like sarcoidosis, even though this is high, it's very different. And then soluble IL-2 receptors can differentiate between CVID with granulomatous disease and CVID with infections. So again, they were really trying to find a cutoff level, and this is what they did for comparing CVID with granulomatous disease versus with infections. The p-value was very statistically significant, and they had a cutoff of 6,376. So this was kind of like the breaking point of when we need to worry about them developing granulomatous disease. It was very sensitive and specific, which I think is awesome because it's a pretty simple biomarker to get. And then looking at granulomatous disease versus sarcoid. And again, the levels were quite high for the patients getting granulomatous disease. So in conclusion, the levels rise with progression of granulomatous disease, decline with remission of it after treatment, and that the levels seem to be promising biomarker for granulomatous disease and CVID. And you can use them as a monitoring tool for evaluation, and also whether or not you need to be concerned, and also whether they're responding to treatment. It looks like there are a few questions about this paper. There were no correlation to ACE levels. They didn't comment on that, and I don't think they got them in any of the CVID patients. Will it differentiate between sarcoid and CVID? The answer there was yes. When they compared them, let me go back to the table, and they specifically looked at CVID different cohorts, but those with granulomatous disease had levels that were markedly elevated comparatively. And then this paper specifically is looking at CVID with granulomatous disease versus sarcoid, and again, statistically significant and pretty sensitive, but not specific. So anyway, I thought this was a good, quick piece that you may not pick up, but I think was interesting because definitely affects or could potentially affect or change our management in the future for these challenging patients. Thank you so much for joining us today. And also, I wanted to just put this out there. Even though we just had an IUIS update not too long ago, we've already had an interim update. The next big update's not until 2022. So we've had so many genes that were described in the last 8 months between the last update. So 26 new defects are in this interim paper. So I wanted to put that on everybody's radar as well, because our field is rapidly expanding and it's hard to, 27. Dr. Romberg's clarified for me, but it's hard to keep up to date. So I just wanted to put that on everybody's radar to also check out. So, and Kate said already 10 more. So now we're up to 37 since our update. Anyway, it's an exciting time to be a clinical immunologist. And I just wanted to thank you all for joining us tonight.